Thank you for asking me to give a talk today for the DARE Fest. My talk today is going to be about the Inherited Metabolic Diseases Service at Guy's and St Thomas's Hospital in London in the context of the Adult Refsum Disease Clinic. So I'm just going to start off with briefly talking about what inherited metabolic diseases are. They're a group of diseases that manifest as a result of dysfunction of either a single or multiple enzymes in one or more metabolic pathways. So essentially, it is a single gene defect in either the metabolism of proteins, carbohydrates, fats, or lipids, and it involves either one of the major pathways or one of the ancillary pathways. So there are a number of genetic defects that are classified as inherited metabolic diseases. And this is a simplified version of the pathway that shows all the important enzymatic reactions and chemical reactions that happen in the body. And this one is a fuller version of that. So as you can imagine, there are a number of different enzymes that act to make sure that the body is metabolizing the foods we eat. And at the moment, there are roughly about 1,462 different conditions that are classified as inherited metabolic diseases. So although these conditions are individually quite rare, they are collectively not that uncommon, and they occur in about 1 in 800 live births. So the Guy's and St Thomas's Centre for Inherited Metabolic Diseases is designed to look after and care for patients with these inherited metabolic diseases. We are one of only 5 nationally commissioned services, and we have seen a huge increase in number of patients who are diagnosed with inherited metabolic diseases. The number of patients in our service has grown by more than 20% in the last 2 years, and this is despite the pandemic. And we currently care for almost 1,000 patients in our clinic. So the core team of the Adult Inherited Metabolic Disease Service consists of the consultants in adult inherited metabolic disorders and a number of other metabolic medicine physicians who support the service. We also have a significant dietetic team with 4 specialist metabolic dietitians and 1 dietetic assistant. We have a clinical nurse specialist. We also have a clinical pharmacist, and we have administrative support staff who help things running. We're also supported by a huge number of laboratories, all very specialist laboratories, including the newborn screening laboratory and the specialist metabolic laboratory that measures phytanic acid levels in our patients with Refsum disease. We also have very close links with the pediatric inherited metabolic disease service, and a number of our patients would have been looked after as children in this service before transitioning to our adult care. Over and above the core IMD team, we also have multidisciplinary team support because we are co-located within a very large teaching hospital that offers acute services, including acute neurology, cardiology, renal, gastroenterology, so kidney and liver. We have physiotherapy, ophthalmology, we have electrophysiology, radiology, and also psychiatry and psychology services, all co-located within the same campus. Of course, we have ITU facilities as well for patients who might need it. And that was the reason behind transitioning the standalone Refsum's clinic at Chelsea Westminster Hospital to our hospital at Guy's and St Thomas's, so that the patients can then avail of the general facilities that are available as part of the Adult Inherited Metabolic Diseases services here at Guy's and St Thomas's. So I'm just going to quickly move on to the Adult Refsum Disease Clinic. We run a separate clinic for patients with adult Refsum disease clinic, and this is to allow other members of the team who might not necessarily be part of the core team to also attend. So Professor Wisbeki and Eleanor Baldwin, who many of the adult Refsum disease patients will know will also be involved in this clinic. So we currently have 22 active patients who are regularly under review in this clinic, including 2 new referrals in the last 2 months. We see the patients separately in the clinic, and as many of you will be familiar, as part of the NHS, the service is free to patients, with all services free. The clinic is run in the early afternoon, and this is to enable patients to negotiate the early morning rush hour a bit easier, and also to ensure that they are done with the clinic and back home before it gets too dark. We do reimburse travel expenses if patients are entitled. We have made some modifications to the clinic arrangements. The clinic is on the ground floor. There's easy access to a blood room within the outpatient clinic department. And also, although a lot of our calling systems are visual, as in the name of the patients comes up on the board when they're ready to be seen, we will have somebody come out and call the patients or flag next to the names of the patients to ensure that people who have got visual impairment are also able to negotiate the clinic. We share care with local services, and this is really important because we cover a very large geographic area, so it might not always be convenient for patients to come up for all their tests to St. Thomas's Hospital, and therefore collaboration with local services is important, and we collaborate with other centres of national excellence, for example, the Moorfields Eye Hospital. Incidentally, quite a few of our referrals will come from Moorfields Eye Hospital, but the initial diagnosis of retinopathy will be made. So in terms of diagnostics, as we all know, plasma phytanic acid levels are the most important, but we now recommend genotyping as a first-line screen for patients with retinopathy and anyone who has characteristic bone abnormalities as well. Again, we know that dietary therapy is the mainstay of treatment for patients with adult Refsum disease. And this is what we do in the clinic with quite significant involvement from our dietetic team. Of course, the data is limited and further research is needed to ensure that we have information with regards to how omega oxidation affects phytanic acid metabolism, whether different people have different levels of enzymatic activity that might have an impact on how severe their disease is, what the phytanic acid content of different foods is, and the DARE Foundation has been really helpful in starting up an initiative to improve the repertoire of foods that patients can safely have, and of course also into other variables which we are still unsure of in terms of the impact they have on phytanic acid levels. So in the clinic on a regular basis, we will monitor for modifiable risk factors that are associated with phytanic acid level changes. So to ensure that the weight is stable, if they're losing weight, are they losing weight too quickly, or do they risk increasing their phytanic acid levels because of the diet they're following, particularly in terms of carbohydrate intake, etc. Eleanor and Sarah will no doubt expand on this. We also use this opportunity to update our patients on any new information in terms of diet, and also to look to see if there have been any difficulties in dietary compliance. To reiterate that any surgical or medical admissions need to be brought to our attention so that we can manage the care for Refsum disease during this time. Any history of any infections, any risks of infection, of course, more recently, COVID, because we have noticed, particularly with some of our other inherited metabolic diseases, that there has been an increase in the need for nutrition and calories, particularly in patients who are unwell with COVID. And if there are any other unknown or factors that may or may not be affecting the disease course in our patients. And then the other major aspect of monitoring patients with adult refsum disease is to look for any nutritional deficiencies that may be associated with the dietary restrictions that patients are under. So we will regularly take a more detailed history and blood work to make sure that these are all in the normal range. Monitoring of the phytanic acid levels, we have really struggled during the pandemic because, again, as we discussed, our patients come from a very wide geographical area, and it is not always easy for us to get phytanic acid levels done for patients um, outside of our hospital. We are working on a way to do some near patient sampling to see if patients can post in their samples. However, there are logistical challenges associated with this, and there is currently an ongoing project within GSTT to try and negotiate these challenges. Of course, we see the patients a bit more regularly, and we try to measure phytanic acid levels more regularly if there are any treatment decisions or management decisions that need to be made based on those levels. So that could be if they've got any new symptoms, particularly neurological, and decisions on whether to carry out plasmapheresis, whether they are losing any weight, and if there are any other intercurrent illnesses that may have an impact on the levels. Plasmapheresis, this is a question that comes up again and again. Obviously, it's not a service that is offered routinely in our service. We only consider it for patients who've got acute or worsening neurological symptoms or cardiac symptoms or of very high phytanic acid levels. Plasmapheresis will no doubt bring the phytanic acid levels down more quickly than dietary interventions. Typically bringing it down by more than 50% with one cycle of plasmapheresis. However, it remains to be established whether these levels can be maintained. We typically notice that there is a rebound of phytanic acid levels after plasmapheresis, and the reason for that is because most of the phytanic acid is actually stored in the adipose tissue and in the liver, and therefore after plasmapheresis there is a gradual rise back again of the phytanic acid levels. Furthermore, more importantly, the plasmapheresis is done to prevent morbidity in terms of neurological symptoms. And interestingly, we have had 8 patients in our service who've had phytanic acid levels of more than 400 micromoles in the last 18 months. So during the pandemic, we have been able to bring 5 of these patients in for nerve conduction studies, and only 1 patient of the 8 has peripheral sensory motor neuropathy, long-standing neuropathy, and none of the patients had any demyelinating neuropathy. So we would normally do the plasmapheresis to improve symptoms of demyelinating neuropathy. And because these patients do not have the symptoms, we have not offered plasmapheresis for these patients. The other aspect of adult refsum disease management, again, is, as you all know, the emergency regime. And I know that Sarah and Eleanor are going to talk more about this, but I will talk a little bit about what we do when patients go on to have acute procedures. So the aim of the emergency regime or the surgical protocol is to prevent a catabolic state that may lead to release of stored phytanic acid into circulation. And this is very similar to the standard practice that we have for all other fatty acid oxidation defects. And the reason we think that it is applicable to patients with adult refsum disease is because of this paper, which was done a while ago in 2003, which showed that phytanic acid doubles in roughly a day if patients are fasting. And patients can become quite unwell. With 1 patient reported to be unwell for about 12 weeks after having fasted, and 1 patient having leg cramps for about 3 days after the fast. And so higher the baseline levels, higher the risk, and therefore the protocol for surgery is as follows. We tell all our patients to get in touch with us if they're going to have an elective procedure at least 2 weeks before the procedure, so we are able to put a plan in place. Obviously, sometimes it can be an emergency, in which case we advise them to contact us directly so that we can liaise with their medical or surgical teams. So the intention is to put in a protocol in place for any fasting, either before, after, or during a procedure that might last for more than 4 hours. And the aim is to ensure that there is a good intravenous access at all times, to have 10% glucose at 2 mils per kilogram per hour going throughout the period that the patient is fasting. And this is to maintain glucose levels and carbohydrate intake to ensure that the body is not becoming catabolic. Now, sometimes, particularly in older patients, what can happen is this level of glucose can cause a rise in blood glucose levels. And the natural tendency for medical teams is to slow the rate of the glucose down. However, we would recommend that in these cases, rather than slowing the rate down, they should start an insulin sliding scale. And there are usually protocols within hospitals to do this. And this would be to maintain the glucose levels at less than 10 millimoles per hour. Obviously, it is important to make sure that the fluid and electrolyte balance is correct, and therefore any fluid and electrolyte balance imbalances should be corrected by giving saline and electrolytes such as potassium as needed. It's also important for patients to ensure that the hospital that they're having the procedure in has access to cardiac monitoring, access to specialist dietetic teams, and also access to ITU facilities should the patients need it. Some of the things to remember are at least our cohort of adult refsum disease patients have a median age which is significantly higher than most of our other patients with inherited metabolic diseases. And a lot of them will have comorbidities such as diabetes, reactive hypoglycemia, hypertension, or heart disease. And therefore, a multidisciplinary approach to management is needed. And also important to remember that pregnancy and labor are a time of increased metabolic stress, and we would do a birth plan for our patients who are going on to have pregnancies. So in terms of other surveillance, we would do a surveillance based on whether there is an intervention that is required or can be done. So, for example, we would not necessarily do surveillance scans or nerve conduction studies on a regular basis. We would do a baseline nerve conduction study and brain MRI scan. Incidentally, brain MRI scans, we have done it for about 30% of our patients so far, and we have started to do that because there were some reported white matter changes in the literature. However, thus far, all the brain MRIs done in our patients have come back as entirely normal. Patients can present with mixed motor and sensory neuropathy. This can be chronic, it can be asymmetric, it can be progressive. Initially, the symptoms can be up and down depending on the phytanic acid levels. However, later on, it does become fixed. And you can have an acute, what they call a demyelinating neuropathy with very high levels. And again, as I said, we have done the nerve conduction studies for quite a few patients who did have levels above 400 micromoles per liter, and we did not find demyelinating neuropathy in any of the patients, and only one patient had a fixed peripheral neuropathy. And the patient who had the fixed peripheral neuropathy actually had the lowest of the levels. So their level was around 415, between 400 and 500. And we have had patients who've had levels slightly higher than that and actually have had nerve conduction studies that have been normal. We will also do a general surveillance of hearing, so regular audiology scans from the age of 50 if required, or if there are symptoms. And of course, eyes will be under regular surveillance, either at GSTT or at Moorfields Eye Hospital as required. Cardiac manifestations, again, in the literature, there are reported cardiac manifestations, particularly during very high phytanic acid levels at the time when patients are really unwell. So we would recommend cardiac monitoring in the acute phase or if patients have been admitted with any acute illness. However, none of our patients have any symptoms which are suggestive of cardiomyopathy. There are other case reports of other comorbidities, including kidney disease or vestibular, or as in problems with balance, and white matter changes in the brain. And we haven't got any of our patients, our cohort does not have any of these problems that have been listed. So that brings me to the end of the talk, and I just want to finish by thanking all the members of the Adult IMD at St. Thomas's, and of course our patients, without whom the service would not exist. Thank you.